So hi, good evening, and now we are towards the end of the sessions, but the most difficult part is at the end. So let me introduce myself. I am Dr. Sommayya Aftab. I am a consultant pediatric endocrinologist, head of department and chairperson of pediatric endocrinology at the Children's Hospital, University of Child Health Sciences, Pakistan. And I'm really thankful to Congenital Hyperinsulinism International, especially Julie Raskin and Jennifer, for giving me this opportunity to represent the developing country on this important platform. I have received a lot of messages by parents and families, especially to say thank you to you, Julie, for making us feel that we are part of this community and for giving us a time to present our challenges. So what we have decided, I will quickly go through what challenges we are facing as a developing country, and then I will need your input, how we can meet those challenges. I think we all know that congenital hyperinsulinism is the most common cause of persistent hypoglycemia in neonates and infants, and early diagnosis and immediate management is the key if you want to prevent neurodevelopmental disabilities. When I look at one side of the world, we are talking about a lot of clinical trials. We are talking about glucagon, we are talking about Sunrise trial, Achieve trial, newborn screening, and it's all amazing work that is really very much needed for the HI community. But on other side of the world, the things are pretty different. Let me share you when I was asked to make a few slides about the challenges the HI community and the physicians they are facing. I keep on writing the number, and the list was like literally 40 and 50. I was like, it's so difficult to talk about that. So I selected the following few, which I feel if we can work on can make a huge impact on HI community in developing country. Delayed presentation, hypo-screen cost, free genetic testing, availability of diazoxide and octreotide, cost of simple blood glucose strips, lack of feeding assistance and dopamine scan. We need trained pediatric endocrinologists and HI consultant and surgical expertise. Let's talk about the delayed presentation. That is the data from my hospital in the last 1.5 years. So in last almost 18 months, total 46 new cases of hyperinsulinism were reported. And interestingly, 41 persons were presented late. They were being mislabeled as epilepsy, seizure disorder. They were taking a lot of list of medication. And what was the reason? A simple blood glucose was not checked at the initial point when these kids presented to the local A&Es. No one even considered hyperinsulinism as the first differential diagnosis. The reason is that there was a lot of concerns. What is the cutoff to take a hypoglycemia? Some people say, oh, 40 milligram is perfectly fine at the time of the birth, and they send the baby back home. So a lot of queries about that. Second thing is that the lack of awareness about congenital hyperinsulinism among healthcare professionals and even HI families, the families that were living in my country, Pakistan, and I believe many other developing countries. What was the solution for that? Honestly, we decided, at least my center, because that is the biggest pediatric center of the Pakistan and the first pediatric university of the Asia and the second biggest of the world, that for the next whole year we will talk about hyperinsulinism awareness so that all our BHU and THQ primary care, they know what is the significance of checking a simple blood glucose at the time of presentation when a child came to you comatose or having repeated seizures. Second is diagnosing hyperinsulinism. As we have discussed even in the last sessions, there's a huge chunk of investigations as per the guidelines we need to do to make it sure that this kid is definitely having a hyperinsulinism. The problem is that free fatty acid is not available in Pakistan. Blood ketones, they are not available in all centers. We are the lucky one, we do have blood keto strips, but it is not available in most of the centers. Secondly, a cost of a hypo screen is actually around a monthly pay of an average worker in our country. I'm not lying, trust me on that. And just imagine, the parents need to pay this from their pocket. So how we were managing? I must acknowledge my team, my doctor, the nurses, they are literally paying for this from their own pocket because every parent cannot afford it. What is the answer for this diagnostic cost? Honestly, I don't have an answer to, but I was thinking that we should talk to our government that at least for certain focal center in Pakistan, maybe one or two, to make available these tests free of cost. I know it's difficult to make it available in all the centers in Pakistan, but at least for the certain focal center. Next is genetic testing. I'm really thankful to Congenital Hyperinsulinism and University of Exeter that they agreed to provide the free genetic testing as they're providing to other countries free of cost. We were struggling in how to pay the courier charges, and I'm again grateful to Julie Raskin who said don't worry about that. We can manage for your patients because they can't pay the courier charges for the genetic testing. So I'm really hopeful to send like 50 or 60 samples in the next few months. This is the big challenge, which I'm repeatedly emphasizing on this platform, availability of medication. First-line treatment of hyperinsulinism, diazoxide, is not registered in many developing countries, including Pakistan. Some of the parents, they are getting this medication at a very expensive rates because that is not through a proper registered pathway. And whenever there is a shortage of medication, the price increased 5 to 6 folds. So just imagine, that is really called a simple blackmailing because they need, their kids are dependent on this medication and they need to purchase this medication through that illegal route. That is not the right way for these patients who are going through a lot, being the HI family. Even if they're available, they are sometimes available for a short period of the time. That is again a big concern. Second thing is octreotide. We do have octreotide in our country, short-acting and LAR, but again, they are pretty expensive. As per our hospital policy, we can provide the octreotide when the patient is admitted in the hospital, but once they are going back to the home, there is no way they can get the free medication. So we normally use to link them to our social services who can provide them or help them in getting the octreotide. What we have done so far for the provision of diazoxides, again with the collaboration of Congenital Hyperinsulinism International, we actually consulted few local companies, national companies, if they can help us in providing diazoxide in Pakistan, and they try to make a collaboration with certain international companies, but the problem is the cost. It's pretty expensive because we are dealing with kids and we need suspension, and suspension is an expensive one. Then we are in collaboration with some other organizations like VEP who are somehow happy to support some of our kids free of cost on a name base, but this is still in process. Let's see where we can reach at this point. What I can feel that the final answer should be the government of these developing countries and policymakers need to be involved, and we need special consideration and grants for these medications. We really need to meet and make an advocacy at a maybe international level, global level, like we did for insulin about an year back, that please make it sure that diazoxide should be available to every kid who need it in developing country. I'm just sharing you here example of hydrocortisone tablet. You'll be shocked to know that hydrocortisone tablets were not available in Pakistan 2 years back. The parents keep on writing to government that please, we need these hydrocortisone tablets. We are purchasing by illegal routes, and finally we got hydrocortisone registered in Pakistan with a very, it's very affordable now. It's really affordable, and that everyone can purchase it by their own pocket. Feeding and nutritional support, that is again a big challenge. I'm not a nutritionist, I'm not a dietitian. I did 2 years of my training at Great Ormond Hospital, where I got a chance to learn a bit from Anna Ruby. But still, we need proper HI trained dietitian. We don't have high carb formula available in Pakistan. Feeding tube and pumps are really expensive, and our population and our people, they are not used to of it. And feed fortification is a difficult task. So what is an answer? What we should do? I was doing some brainstorming, and I really feel like for other organizations, can we start a mentor-mentee program on a platform of Congenital Hyperinsulinism, where a dietitian from underprivileged countries, they can be linked for 3 months or 6 months virtually with a trained dietitian, so that they at least know how to manage these kids. Secondly, support for feeding tubes and pumps. I know it's a big task, but we don't have these tubes and pumps available. Even if you got a tube, the pump is pretty expensive. The last is that we really need the local guidelines for feed fortifications. I know there are some centers who don't believe in feed fortification, but trust me, we have made our local guidelines by using our local formulations like Fento malt and icing sugars, which is working well. If it's working well, it's good for me because I need to give something to them. Then we talk about 18F DOPA PET scan. PET scan is available in Pakistan, and 18F DOPA scan somehow, fortunately, is available in my city, but the problem is it's very expensive, and we need expertise to do it and to interpret the results, because we did few 18F DOPA PET scan and the results were like normal. Even I was suspecting a focal disease because it was a paternally inherited condition. I was like, it's not making sense. And the last thing is that problem with the dye stabilization. So I talked to my nuclear medicine consultant and head of departments, what we can do for that. He said, we actually need training. We do have an equipment, we do have a dye, but we are not equipped or trained to do that. So if we can get support in that, and I think we have started working on it. We need HI trained consultant and surgeons because it's very important. The people think that hyperinsulinism could be managed by any pediatrician, which I don't agree, because it is a very specific field, even supra specialty, and an HI consultant can understand why it is important to monitor the blood glucose and to check the blood glucose, and we really need to work on that. Secondly, for that we need to go for capacity building, which we have already started, but if we can make a focal HI center training, including dietitian, doctor, surgeon from the same center, which later can do capacity building for other centers, that would be great. Instead of choosing different people from different centers, which I think is not going to end up in a good teamwork. So these are my suggestions, my last slides. I really feel that we need to go for HI awareness webinars for families and HCPs. We are in strong need for guidelines for resource-limited country, like we have discussed, that if you are in resource-limited countries, GIR is really high, don't go for cortisols, it looks like in hyperinsulinism. We need to make a collaborative effort for availability of diazoxides, training of a team for a focal center, capacity building, and if possible, for CHI fellowship or grants for developing country. These are last slide for a hope. These are the children who are living in different part of Pakistan. They get management from my focal centers, Abira, Zohan. They said, please call my name over there, so that's why I'm taking their name, Ishal. They were living normal life, but I know, other than our effort, their families have put a lot of effort just to make it sure their kids get medication, they're selling their properties, their stuff, so that their kids could have a normal life. Well, thank you so much. This is my city, Lahore, full of colors, and at the bottom, you can see my hospital, the Children's Hospital, University of Child Health Sciences. I have a big support from my hospital, but definitely we do have some limitation because of resources. So thank you so much. If you have any questions, we can proceed further.
Yeah. Quite a few questions in chat, but if there's anyone in the room who wants to ask anything first, I'll be there. I'll just take that away. Thank you.
Because of the way that because of the way this is,
You can just push it up. You might need to speak further into it. Just talk.
yeah. Because of the way that Pakistan's set up, do you feel like there's a lot of cases that go just undiagnosed and they're just passing away and it's attributed to
That is a
early
really,
infancy death?
Yeah, very nice questions. I 100% believe what you're saying, because my city is a metropolitan city, it's a big center, and I'm pretty sure many of the kids, they haven't even get access to reach to our center. And when I talk to the families, like I have in last year, we got 50 new families, and you'll be shocked to know that some of their kids passed away and they were not aware, and I believe they might be having hyperinsulinism, because they told me, oh, they were having fits, they were having low sugars, the doctors keep on giving this, and then we came to know there's one center in Lahore who is somehow having expertise in managing this condition, so that is why we traveled all across for like 12 hours and 18 hours So I agree with you, there must be a lot of underdiagnosis.
I was just going to add to that. I think this is a very important topic that needs to be made public. So if there are physicians for resource-limited countries listening, I think we need those publications. I think we need to publish those cases where babies are dying because of hyperinsulinism, because otherwise we're not going to get those government and the society to mobilize to prevent that.
Diva, can I make a small comment on that? I know it's, even if we want to go for some publication, you know, all the good journals, they have processing charges, which is more than my pay. Literally, more than my monthly pay. And I was like, okay, then we go for some local journals. We are going to have a very interesting article on neurodevelopmental outcome of congenital hyperinsulinism of 2-year experience in our center, and we are soon going to publish it. But we do have some limitation in publication sometimes.
Yeah.
Two ideas on that.
Yeah.
One, the HI Global Registry does collect the full life and sadly the death. So if there's a way for the families and the physicians to complete the max figure, that could be done. And secondly, that's an interesting idea to have some kind of program to cover publishing costs. I really like that idea. That could be a very efficient way of bringing more professional voices into the conversation.
And Julie, can I ask you for HR registry, because most of the population in developing countries, they are not that much literate that they can fill the English performers and all this stuff. So is there any way a physician can help them in fill the forms, because they don't have emails? I tried to send that link to like 50 and 60 patients, but it was like, we don't know how to do it. I was like, if you allow us, especially for developing country, the physician has an access to fill it, because they don't have an email ID, so you can get a lot of data.
Yes, as long as the patient is willing, the caregiver.
Yeah,
Absolutely. Yes.
Perfect.
Thanks a lot. So I was just wondering, you said you had 46 cases over 2 years.
Yeah.
That's a lot of cases. How large of an area are you covering? Do you have any estimation of the incidence? Because there's also an opportunity to actually be some of the experts here, because if you have an incidence that is far higher than some more developed countries. So yeah.
So in Pakistan, I'm literally saying that we are underreporting even this number, because in Pakistan we have a lot of cousin marriages. So that is the reason the incidence of hyperinsulinism is pretty high in Pakistan. And I'm just giving you data from my center. There may be other centers from Karachi, Aga Khan University, they're doing a great job. We have NICH center, we have Lathan center, they have their own data. But our center, because the biggest center, we have the huge number of patients. I don't know exact incidence, to be very honest, because I don't want to give any false number, but I'm pretty sure, because in my department, every week, 1 or 2 new HR are admitted. Some are literally 1 or 2, and they are being referred by different centers, and that is the second most common admission is hyperinsulinism after DKA. Yes, please.
When you say 46 cases, is it genetically confirmed or clinically confirmed?
You can say like maybe half of them are genetically confirmed, maybe less than half, and the rest genetics I need to send actually.
Okay.
Yeah.
Thank you.
But our cases are pretty clinically, they look like a hyperinsulinism, very high GIR, and we can clearly see that insulin levels are detectable, ketones are not they are hypoketotic, so we are pretty sure they are hyperinsulinism.
Alright, if it's alright, I'd like to turn to the questions we have from the virtual chat, just with the time we have. First question coming from Jamaica. We only have affordable access to a brand of diazoxide by the name of Balila capsule. Sorry about that. These are then made in suspension by the local pharmacist. Can you speak to how we can access diazoxide that is already in suspension?
So that is a very difficult question for me actually, because I'm myself struggling to get diazoxide in my country. There are a lot of brands in the company. I know there's Udemine, Proglycin, Belila. To be very honest, that what is my experience is mostly on Proglycem, so I don't know about the other brands, so I can't comment about how they are. But honestly, in our country, we are struggling. How we can, I think your local national companies, they need to talk to the multinational, international companies who are providing diazoxide. They need to sit together, they need to do a meeting to fix some certain costs that they can provide to developing countries, and then they can take a draft permission, and that is how the orphan drugs, they can get registered to any country. The only issue is the cost, because we tried multiple times. Even recently, a month back, there was a discussion between two companies, but the problem was that the cost of suspension is pretty high. Pretty high for us, actually. Maybe it's not for you guys. It was $100. Yeah, please.
Yeah, it's even more expensive in our country than I believe the price that could be available in Pakistan. But the difference is that most children in the United States have a third-party payer, so they have either private insurance or the government is, through our government insurance, like Medicaid, is covering it. So that's really the big difference. And the question is, one area of advocacy, and I don't know the situation in Pakistan, but I know that, for instance, in the Philippines, we've explored, there is the possibility of having medication added to the list of essential medications that is then covered by a government-sponsored program. So the question is, in Pakistan, is there anything? Are there some drugs? Oh, in Jamaica,
yes.
Are there some? That's the question. And now we have diazoxide on the World Health Organization list of essential medications. We have a list of essentials on the congenitalhi.org website that's agreed upon by the whole collaborative research network. So I think we need to build a case in Jamaica for this to be covered by the government and see what that would entail.
I think that would be great.
Okay. Mohammed Zahid from Pakistan asks two questions. One, how can we start weaning of HI children? And two, do HI patients spontaneously resolve at puberty?
So, again, it depends upon which type of HI. Fortunately, I'm not sure what is underlying diagnosis or genetics, because we are not having genetics for half of our patients, but some of our patients are really mild, and I can clearly see that they are coming out of the disease. When I say coming out, it means that I'm not increasing their dose of octreotide or diazoxide. They're on the same dose, even after a year or 2 years. But what is the long-term prognosis? I honestly don't know.
And Khanda Fishan Mumtaz, doctor, asks, at what age can we start uncooked starch to prevent frequent hypoglycemia, as many patients cannot afford Fentanyl?
That is again a very nice question, because I know the recommendation is that please don't start cornstarch before the age of 2 years. But in our country, we are giving cornstarch as early as 6 months of an age because it's working, simply. We do have sometimes GI side effects like clotting and diarrhea and vomiting, but not with every case. Even for the fentanyl, it is not recommended to give less than 2 years. But we are using fentanyl because we don't have Mexijul, we don't have that simple glucose. And when we try to make recipes of high glucose by using simple dextrose, they had a very high content of vitamin D. So I was concerned that if I'm going to add that dextrose in recipes, it would lead to vitamin detoxification. So I was like, no. So that is why we're using fentomol. Fentomol is basically a dextrin and maltose polysaccharide, which is actually being used for GST treatment, glycogen storage disease. So we are making its recipe for our HI kit, and it's working good. And if it's working, I'm happy.
And Dr. Khanda also asks if you can highlight any surgical options that are available for HI patients where GIR is very high and patients cannot afford sandostatin or diazoxide.
I would like to request Diva if you can answer that question, because if in our country we do not have diazoxide and sandostatin, do you think having the surgery is a good option, but we don't have 18F2 PET scan, no genetics. So what is your thought about that? How are we going to do surgery?
I think that's a very difficult question, but I do want to say that even in my hospital, sometimes we do a pancreatectomy because at some point it's a balance about wanting to prevent the long-term effects of removing most of the pancreas versus ongoing hypoglycemia and the risk of brain damage. So I think as much as in the current state with limited medical options, sometimes the best option is to make a decision about doing a pancreatectomy earlier rather than later. But I think through the tools that Congenital Hyperinsulinism International has put together in countries where genetic testing is a possibility and imaging is a possibility, you first really should rule out the possibility of focal disease, so only the area that is affected is removed.
And especially even for the surgery, like they were the first few cases which are very challenging for us. Even we arranged diazoxide and octreotide on maximum doses, the kids were not responding. We had a huge discussion with the family that we need to go for pancreatectomy to save the life because we can't keep the kid on IV for long. They were like, how much chances of recurrence? I was like, there's still a chance. I'm not 100% sure because we don't have 18F2 PET scan. We don't have like genetics even still. So most of the parents, they refuse that when they listen, oh, there's still a chance of having that again, 100% guarantee that it will cure the condition. So that is also very important.
Yeah, I just want to underline that. That unfortunately, in the case of my son, he had 3 subtotal pancreatectomies, more than 99% out, and he still was on octreotide until he was 9 years old. So it's just a very unfortunate reality. He was one who probably to this day would have had a subtotal pancreatectomy. So I'm not saying don't do it.
Yeah.
I'm saying we need those drugs available to those kids as well.
Yes. I'm happy that there's a lot of families and the doctors that were on live stream.
Yes, absolutely. Yeah, it's a great way to connect. So we actually have another question from a dietitian, Sommayya Aftab from Pakistan. Question is, can you please highlight the feeding practices, like how we can fortified feed locally? Kindly highlight the dietary management in each one.
So, what we are struggling in developing countries, because there's a strong advocacy of our breastfeeding, because in developing countries we always encourage to have a breastfeeding. That is the biggest challenge, because when you're managing a kid with severe hyperinsulinism, we cannot quantify breastfeed, so we need to go for EBM, and many of the doctors, they don't agree to that because they feel like, don't go for EBM, you are basically promoting malnutrition, but they need to understand the need of an HI at the same time. We need to fortify the EBM by giving added sugar. So what we are practicing in our part of the world in my centers, we are adding fentomalt or icing sugar in the feed to increase the glucose content to 12%, 14%. That is how we're managing. We normally used to start with 2 hourly feed, and then after starting the medications, like the other centers are used to do, we do a proper fast and safety fast to make it sure that how long they can tolerate fast, and after that we can space out the feed according to the fast tolerance.
I think we still have time. There's a lot, thankfully, a lot of engagement. It's really nice. And we have Dr. Sajjad Habibullah asking, are neurodevelopment outcomes prevented after pancreatectomy?
So again, I would like to request Diva to answer that.
Yeah, so the studies that have been published have shown that adverse neurodevelopmental outcomes are common to all forms of hyperinsulinism, including the transient forms that resulted in the first few months of life, the focal forms that are cured by surgery, and the severe forms that require near total pancreatectomy. So it's a very complex answer to that question. But I think that because of the brain damage, there are many factors that contribute to the development of brain damage, from the time of the first low glucose to the ongoing hypoglycemia, until we prevent hypoglycemia from day 0 in these babies. We're not gonna solve the complications in terms of brain damage.
And we have another question from the chat. Is, I'm going to struggle to pronounce this, nifedipine more readily available CA2 channel blocker? And has been previously reported as helpful for some?
For calcium channel blocker nifedipine, honestly, my experience is not that good. I'm not sure what is your experience about that. Even when I was working at GOSH, for PMN2 mutations, we tried nifedipine just because it lowers the blood pressure, and we feel like it will work as an adjuvant therapy to manage hyperinsulinism. My experience of calcium channel blocker is not good, but Deva, if you want to add something.
Yeah, so that was the topic that we discussed. We discussed when we were writing the international guidelines, and the collective experience had been that calcium channel blockers like nifedipine are not helpful. There are some specific forms of hyperinsulinism where the mutation is in the calcium channels of the beta cells. So in those patients, it should be considered, and it may be helpful, not in all those cases, but in the rest of forms of hyperinsulinism, it has not really, it's not an effective treatment.
I agree to you because
Definitely we'll have to respond to some of these afterwards, unfortunately. But we have another question. For HI diazoxide responsive children, the guidelines are still not doing a PET scan, as they are all diffuse and don't need pancreatectomy if HI is medically controlled. Or should we do PET scan to confirm if they are diffuse or local?
Deva, would you like to comment on that for diazoxide responsive hyperinsulinism?
I'm happy to. And I would first say that you should look at the guidelines, so how we define diazoxide responsiveness, because I think it's important to truly demonstrate that the child is diazoxide responsive. And if you do truly demonstrate that the child is diazoxide responsive, then imaging for focal disease is not indicated, because we understand very well the mechanism that is responsible for focal hyperinsulinism, and understanding the molecular causes of focal hyperinsulinism, we know that those children don't respond to diazoxide. But again, it's very important to establish unequivocally that the diazoxide is not working.
And even in developing country, having the surgery is not that easy job. We need an expert surgeon for that. And even after surgery, there are a few complications that we need to manage, like crayon, which is again expensive medication. And again, availability of crayon is a big issue in Pakistan. And then diabetes we need to manage long term if you are thinking about a near total pancreatectomy. So we need to keep in mind that pros and cons. If the child is managing very well on diazoxide, I don't think so we should go for pancreatectomy.
It is 5 o'clock, unfortunately. I don't know, should we go a little over, or we can respond to these later? Julie?
Is it still going, the live stream?
Yes.
If everybody wants to, 5 more minutes, but hard stop at 5 minutes.
Are we okay with that?
Yeah.
Okay. Here's another question. Most kids with HI are overfed to avoid hypoglycemia, which increases their BMI. How can we manage this issue?
So I think we need to find out the best treatment strategy for them so that they can maintain their so they can prevent their hypoglycemia without overfeeding. That is our aim actually. And if we feel that we need to feed every 1 to 2 hourly, even on the maximum medication, that is an indication, I believe, to go for pancreatectomy. If the mother is feeding every 1 hourly because of fear of hypoglycemia and there's no quality of life, then you could consider about this surgery. Otherwise, your management is not working if the BMI is increasing.
We have another question. Are there any clinical clues to focal disease so that we can shortlist patients for surgery?
To the best of my understanding, clinical clue, I don't know about that. They present like other hyperinsulinism, except that genetics, which predominantly inherit ABCG mutation, but they might would like to add something.
Yeah, there's a lot of overlap, but there are some focal cases that are as severe as diffuse cases, but what we have found is that children that are diagnosed after the newborn period, 2 to 3 months of age, and are diazoxide unresponsive, and they had had a normal birth weight, they're more likely to have focal hyperinsulinism than diffuse hyperinsulinism. So there's some clinical clues that made you suspect, but there's also a lot of overlap. However, the genetic testing is highly accurate to help identify those focal cases. So if at all possible, and it's possible thanks to Congenital Hyperinsulinism International and the Exeter lab, getting genetic testing would be very helpful to really identify those with likely focal hyperinsulinism.
Regarding blood sugar monitoring, at what interval blood sugar be monitored where CGM is not an option due to cost?
It depends upon the fast tolerance for that patient. Let's say if a child can fast for 18 hours, I will not ask him to do the blood glucose monitoring until the kid is sick and unwell, or if there's any concern. But if the kid is having like fast tolerance for 2 hours or 3 hours, then I will make it more frequent. So it's very individualized.
And can we use octreotide every 3 to 4 hours, or it can be used TDS? What are recent guidelines?
So in my center, we normally use octreotide either 8 hourly or 6 hourly. In some cases, we saw that 4 hourly is needed, but that is the rare conditions. We really feel like in some cases we really need to move to 4 hourly, but never less than 4 hours.
Maybe last question. How can we differentiate between focal and diffuse forms of congenital hyperinsulinism in resource-limited settings?
Genetics. Because now we have free genetics thanks to congenital hyperinsulinism. We can easily identify the focal conditions, and the rest we can clinically see. If it's very unresponsive, it's a diffuse disease, we are moving towards a PET scan.
That's probably it, so the other one's a little bit longer.
Yeah, thank you so much. Again, congenital hyperinsulinism, and at this point, I want to thank my department. I have my clinical fellows, my dietitians, my doctors who are working day and night for these kids, and my patient and families who are being the biggest support to us. Thank you so much.